Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Jonathan Bushman. He's a family physician. Today's Kevin MD article is The Hidden Moral Injury Behind Value-Based Healthcare. Jonathan, welcome to the show.
Thank you. Thanks for having me.
All right, so just tell us a little bit about your story, and then let's jump right into your Kevin MD article.
Sure, absolutely. So this is a tough one. I had a colleague reach out to me and wanted to speak about their experiences. They're 2 years out of residency. I mean, she's basically feeling a lot of feels, right, in
Yeah.
practice and trying to figure out like I prepared my life for this and I'm going in and out of practice with my patients and I'm loving the aspect of taking care of them. But I get outside of the exam room and I keep getting told to do different things.
Hmm.
And one of the things that just hit her on a different level that she was just really wrestling with was this idea that because of the value-based payment model that they're under, that a few of her patients who happen to have higher A1Cs were representing some bad data in her profile.
Yeah.
And the idea, which was given to her by a mid-level manager, was, perhaps we can just take those people off your panel, but increase your data, make your data look better, and you'll be able to keep the biggest part of your payment through this value-based contract. And she was like, no, there's no way. You've got to be kidding, right? Like we're not doing that. Like that's
Hmm.
unethical. And she was very, very adamant, that's unethical. I'm not doing it. And they said, well, okay. They kind of let it go at the moment. And a few weeks later, she's going through her panel. Patients now were listed as no primary care provider. And of course, she throws a fit. And the first thing is said, well, they still can see you. We just don't assign them to you so that you don't get the bad credit for their A1Cs,
Yeah.
right?
Yeah.
And she's sitting here going, how does this make sense? And how can I don't understand how they can do this? And then I told her I'm in direct primary care. I've been direct primary care for 6.5 years. And so this is some of the stuff I ran away from. But I
Yeah.
remember specifically 10 years ago in a medical group meeting, there's probably 50 physicians in the room, and they described what value-based care was and these models that were coming out for payment and the enhanced payment if you could get the quality metrics. And this was all kind of new to us at the time. And I remember raising my hand in that meeting. And I said, how long before the smartest people in this room figure out how to get rid of the worst patients?
Hmm.
Not that I was in support of that, just saying like it is completely evident to me that's exactly what's going to happen here. And
Yeah.
there's like, no, 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 that'll never happen. And then sure enough, you start seeing more and more of the pay tied to those metrics. And this really is the basis of that moral injury that we all talk about in burnout. And
Yeah.
the more you speak up about it, the more you become quote unquote the problem in terms of the system. Like, it's just, you know, show up and shut up, right?
Yeah.
Keep
Yeah.
it
So
up.
when this physician, fresh out of residency, and you practice to take care of those sick patients, but in a way you're being told by people who focus on analytics that sometimes having that sicker panel isn't necessarily beneficial in that value care model. Just for
Absolutely.
those who don't understand why, who aren't versed in the specifics of value-based care, why is it that having those sick patients, why does that adversely skew the economics?
Yeah, so for the providers, and by the way, value-based care, I'm not saying it's all bad because there's a lot of really, really good things that it's brought. But to say it's value-based care is a really, really broad term. We don't really know what that means until we look at the basis of the contract and the details. But if part of my compensation is tied to what you do, whether that's through compliance or just you take good care of yourself and you meet these quality metrics, whether it's your blood sugars or screening exams, et cetera, that relationship that we have with patients,
Hmm.
that is first and foremost. And when we tie a portion of their outcomes or a portion of their choice and autonomy in their own care, now we've entered a third party's entered into that relationship and said
Yeah.
this looks different. It feels different. And I remember specifically this happening to me about 8 years ago in a lady that had a very similar situation. She comes in, she doesn't want any screening exams. She's diabetic and really doesn't want to take care of a whole lot. And you know what? As much as I loved her, I, I didn't push her. I basically said, listen,
Hmm.
I get it, but I will never get rid of you as a patient because you need me.
Yeah.
I need to be here for you. But something that really bothered me in that moment was that I looked at her differently than I had the 2 years prior to that part of my contract being changed. And that's really, as I described in the article, that's the moral injury when we start looking at patients as transactional, as part of my metrics, part of these measurements that are tied back to my compensation versus just you are who you are. I'm going to respect that. I'm going to give you my everything. I'm going to always promote your health. But at the end of the day, you get to choose how you live,
Hmm.
right? That's autonomy. My job is to make sure that I provide the education tools and the the things that you need, whether that's medications, referrals, et cetera, right? We are doing what we can to put the needs in front of the patient, and the patient gets to choose how they do that. But yeah, when we tie the payment to it, we're opening up this potential for looking at the patient differently.
Hmm. And in your article, you make that distinction between moral injury and burnout. This
Hmm.
example that we're talking about, how quantifying patients and being incentivized to meet metrics, that's a specific example of moral injury, right?
Exactly, exactly. And I think people misuse the term burnout a lot.
Mhm.
Burnout can happen everywhere. It does happen everywhere, but burnout really is just emotional exhaustion, right?
Yeah.
Moral injury is different. And I think physicians get mislabeled as being burned out when honestly they're they're morally injured. And when that happens, and I think this physician's going through this dilemma themselves, they're early in the career, they're still paying off debt, they're under contracts, trying to figure out how do I go forward with this? I can't ignore it, I can't unsee it, I can't unfeel it. Where do I go with this?
Hmm.
And that's the dilemma, and it's a moral dilemma for them. It's like I almost have to participate in this, but I don't feel right about it. Or I can just get out. But there's going to be a huge cost for me to get out of that system. And that's the dilemma for them. And that hurts. Moral injury truly is where you know that what you're doing doesn't align with your values.
Hmm.
And that's exactly where she's at. In fact, she's loving the rest of her career. She's busy, she's enjoying so many parts of it. But when you start to not believe in the system that's been built around the relationships you're building with patients, that's hard to show up to.
And
And
there's a certain amount of irony as well, because
mhm,
this physician worked for a quote unquote not-for-profit system,
mhm.
but being so focused on the financial incentives, it's a little bit counterintuitive.
It really is. And I mean, it's not unique to this system. It's not unique to a lot of systems. And I think there's been quite a few writings. There's been great articles, books. I know Marty McCary's book and the
Mhm.
price we pay. I mean, he highlighted this nonprofit health systems that sometimes they were actually the worst actors in the system. And that the whole basis for a nonprofit organization is to benefit the community or to have specific beneficiaries. And when when patients get looked at as benefactors rather than the beneficiaries of healthcare, we have a problem.
So the whole point of value-based care is that we wanted to get away from that fee-for-service system
Mhm.
where the more we do and the more patients that we see, the more the hospital will get paid. Now, in your opinion, by sharing the story, where do you think we went wrong when it came to implementing value-based care?
So, yeah, and a great little overview of value-based care. Of course, I mentioned I do direct primary care. That's 100% capitation, 100% prospective upfront payment, right? Where fee-for-service is retrospective payment, all based on the code and the service. Value-based care is everything in between.
Mhm.
You can have this little partial capitation, 10% and 90% value-based. You could have 90% fee-for-service and 10% value-based. That's why I say value-based is not real descriptive,
Mhm.
right? We don't really know what that means. And if you've seen one value-based contract, you've seen one value-based
Yeah.
contract. And the problem behind the system here is that the system is working with bigger players, bigger payers. And these bigger payers are saying, we want to know that the monies we're spending in your system are yielding outcomes. And somebody has to come up with these measures. The trouble is the monies flow from that entity through the health system, which then has contracts with its employed providers, and those contracts have different incentives. And so, you know, in the case of this, the physician, a mid-level manager is trying to do their job, right? Hey, I'm just trying to help you out. I'm trying to help you get a full paycheck. I'm trying to help you get that bonus. But in essence, they're really working for the system because the system's under the contract with some larger payer. And the physician's none the wiser. I don't know who these patients are. I don't know who the payers are. I don't know if they're insured, uninsured. In many cases, they're told not to care about that. But at the system level, those incentives have come from the top down, and sometimes even good intentions at the top level by the time they get down to the exam room level have been lost. And it affects those relationships that we all get into medicine for. It's with patients.
Now, when confronted with that moral injury where those financial incentives interfered with your motivation of being a physician, you obviously chose to go in one direction, doing a
Mhm.
direct primary care practice. What kind of advice did you give to that physician who shared that story with you? What did you tell her?
Well, in full disclosure, I mean that's kind of why they're reaching out is like, tell me why you went into this model. Did you go through the same things? And she had a pretty good idea that I had, and she wanted to know the stories. Like, what was this? And I'm
Mhm.
going, yeah, I went back to that same meeting. Yeah, I had this thought 10 years ago. Like, this isn't new. It's new to you. You're really experiencing this for the first time, and this almost this betrayal of everything you believed in about what you were getting into, and that you've devoted the last decade of your life to get in the position to help people, right?
Yeah.
You've worked so hard to get there, and you've been taught to think, think independently and think critically. And now you show up and you're in your job and you're told, don't think about that. We'll take care of that for you.
Hmm.
Don't think about that. We've got you covered. It's like that hurts. That really hurts. And so the advice I gave to her was, listen, you did dedicate your life. You're the one who made the sacrifices to get to the place that you have opportunities. And while you can continue to do what you're doing, and I'm sure you can find the silver lining in everything and make a great career of it, perhaps you listen to your heart and you say, hey, what is it going to take for me to get closer to my patients? It doesn't mean I'm anti this or anti that, but what do I have to do to be absolutely pro patient? And I think in her case, she's really leaning in that direction, saying, you know what? If I could align the incentives directly with my patients, like you have in this model, that just seems like it's very attractive. It's very attractive from the emotional sense of care.
Now you've been doing direct primary care for the last little while now. Has it been the panacea of what you expected? Has it been everything that you hoped it would be in terms of bypassing that moral injury that traditional healthcare systems place on physicians?
For me personally, absolutely. I mean, do we still deal with troubled system in many ways? Absolutely, we do. It's kind of funny, I have a lot of colleagues that have gone into direct care that were really running away. They're running away from the system as we know it. And then there's some that have run toward patients. I kind of feel like my experience was a little bit of both.
Hmm.
I was ready to get away from what I was experiencing, but I was so ready to be closer to my patients, to not have those barriers, to have more time with them, better relationships. But I'll tell you, there's a lot of things I didn't anticipate about direct primary care. Good things that I have found. The feeling of abuse. And what I mean is abuse by patients. So, you get called after hours, people try to get free advice, or they stop you in the grocery store, or
Hmm.
all these things. A lot of my colleagues, if they're not at work, you don't find them out in public. They don't want to be in public. They don't want to go to the grocery store. I love the grocery store. That's where I get to see my patients being normal human beings, just shopping with their families, right? I love it. And if they have a medical question for me because they're members of the practice, that is not abuse. That is just absolute service. It doesn't bother me at all. I never expected that. I was a little worried that I might get, this unlimited access. They're just going
Hmm.
to run over me, and that has not been the case. Not at all. I've gotten to know them at a deeper level. They've gotten to know me at a deeper level. And so you call this the panacea. I've never thought of it that way, but in many ways it has become that way. And one of my teenagers asked me, we're driving down the road. She randomly asked me a while back. She goes, "Dad, do you feel like you're the very best doctor in town?" I'm like, whoa, hang on a second. Number one, no, I never think of myself that way. I'm curious why you're asking, but I kind of sat with that for a little bit and I said, I'm the very best doctor I could be. I now can say that I'm the best doctor I've ever been. Um, and whether that compares to someone else or how it compares to someone else, I'm not really concerned, but I'm where I need to be. I'm doing what I need to do. And there's nothing more gratifying than that for me.
We're talking to Jonathan Bushman. He's a family physician. Today's Kevin MD article is The Hidden Moral Injury Behind Value Based Healthcare. Jonathan, let's end with some take home messages they want to leave with the Kevin MD audience.
Absolutely. I think for patients to recognize that there's a human being behind the interaction with you as well. And physicians, in many cases, are feeling some pressures that are outside of the relationship you have with them. And they may seem rushed, they may seem short, they may even seem like they're a little pushy on you. And perhaps the relationship that you once had with them is degraded over time. And I want you just to consider that these are real human beings, probably dealing with a whole lot more than what meets you at surface level. So show them some grace as we show our patients grace, and know that there are questions you can ask them, and there's nothing more important and nothing I'm more grateful for than patience when I walk through the room to stop before I can even start the visit and say, "Hey doc, how are you doing? How's your family? What have you been doing recently?" Like, I never used to get that. And relationally, we're there now. But looking back, I think about where I came from and where I'm at now. And that would be my message to patients is take the time to ask your physician how they're doing, because they really are human beings that are feeling a lot of things. And it may be distracting your visit and distracting your relationship with them, but they care to be known as well. For clinicians, I feel you. I've been there. I really, really hurt when I listen to physicians that have gone through what my colleague went through here recently, because I understand the feeling of that betrayal, that pull, and the frustration and the questions that it leads to. And know that you're not alone, but also know that there are various different fixes or various different opportunities. And you did get into this career to make a difference in people's lives. And if you're in a current place that you don't feel like you're at your best and practicing your best, look for it, create it. It exists, and you can go after a model of medicine that really is completely satisfying and fulfilling.
Jonathan, thank you so much for sharing your story time and insight. And thanks again for coming on the show.
Absolutely. I appreciate you having me.